Hi, everybody. My name is Ilya Igolnikov. I'm a physical medicine rehabilitation specialist at the Boulder Center for Orthopedics and Spine. Today, we're going to talk a little bit about lumbar disc injuries, everything from the natural course of this disease process, the prognosis, and the different treatment options. Disclosures for today's talk: no relevant financial relationships to talk about. No off-label use is going to be discussed in this presentation. I did grow up in Colorado, not the most recent version of Colorado that we are unfortunately becoming known for, but I grew up here and enjoy spending my time outside enjoying what Colorado has been known for hundreds of years. The learning objectives from today's talk: we're going to introduce and talk about the nomenclature and define the anatomy of the lumbar spine and different types of pathology. We're going to discuss expected natural history and the prognosis of this disease. And then we're going to try to understand conservative and more interventional options for treatments of low back pain that shoots down into the leg, often called radiculopathy or sciatica. Caryn is a physical therapist that works with us. She's going to talk about incidence and physical therapy treatment options. And then I'm going to talk to you about different epidural injections that are commonly used to treat this, as well as some surgical options. So the lumbar disc, a normal lumbar disc has two different areas that are important for us to understand. There's the nucleus pulposus as well as the annulus fibrosus. The annulus is the outside edge of the disc, and the nucleus pulposus is the inside piece of it. I often talk about this in reference to, or as an analogy, I use a jelly donut. It's soft, gelatinous on the inside and has a hard fibrous edge on the outside that kind of keeps everything contained inside. Now, there's different types of pathology or problems that can happen with that. Fissures of the annulus or the outside of the disc can result in a loss of integrity. It is present in a lot of or nearly all degenerated discs, and it is seen on an MRI, as we can see here on the right, as a localized high intensity zone. So you can see that right here, this bright white piece on a T2 weighted MRI image is the high intensity zone, and that is edema or damage to that annulus fibrosis. Now, more chronic setting, disc degeneration can look like a couple of different things. On the left here, we see an example of spondylosis deformans, which is a consequence of normal aging, and you see these bone spurs on the outside of the disc. This can be the front or the back of the disc, an anterior or posterior osteophyte. And you see this white thing here is the bone spur, and this is the kind of chronic degenerated disc. And we see this often, when your body has these disc injuries and they protrude towards the front or the back, your body kind of lays down this extra bone to kind of contain that extra disc fragment. And then this area on the right, this schematic is what's called intervertebral osteochondrosis. And this is more of a consequence of arthritic process like rheumatoid arthritis, psoriatic arthritis. And you can see more the disc end plate here is damaged, and you see more damage centrally here, and the periphery of the disc maintains its shape and structure. And now I see a lot of patients that come in and they talk about having a disc herniation or a disc bulge, and I think it's really important to properly define these terms. So a disc bulge, as we see here, is any sort of really circumferential flattening. So I talk to patients about when you have that donut and there's no injury or hole on the outside edge of the donut, but with repeated use, wear and tear, if you continue to have flattening or axial loading of that disc, you'll eventually have flattening or increased area circumferentially, so all the way around or part of the way around a significant portion of that disc, and that is a disc bulge. Now, in contrast, a disc herniation is when you have a focal piece that has bulged out or protruded or extruded, as we see here. And this is more of a result of an acute traumatic process. So you can probably imagine if you put a really high force through that disc, you tear through some of that annulus fibrosis and that jelly comes out. So this is the equivalent of having a hole in that donut. And if you bite on one side of it, on the opposite side of where that hole is, that jelly squirts out from the other side. And so a disc herniation can really be defined as three different subtypes. A protrusion, as you see here, is when the base of that injury is wider than the edge. An extrusion is typically related to a higher force injury, is when the edge of that herniation is wider than the base or the stock. And a sequestration is when you have such a high force that a piece shoots out very aggressively and loses the connection or the stock to the disc. And these are important to know because these different types of injury, whether it's a disc bulge or a disc herniation, and the different types of herniations have varying types of prognosis. And we'll talk about that a little bit later, but I thought it was very important to kind of differentiate the types of injuries that we do see with disc injuries. And so I also wanted to throw in a public service announcement. You know, the term herniated disc or bulging disc does not imply any knowledge of necessarily the etiology, the prognosis, or the need for treatment. We see patients all the time who have these findings on their MRIs and they're totally asymptomatic. So if your story matches these findings, then I'll talk to you about your prognosis or the treatment options. But just having these problems on your picture does not mean that you need to be in pain or you will forever be in pain or that there's no hope to your treatment. So I always treat patients' symptoms and I don't treat their pictures. And I use this example down here on the bottom right to demonstrate that. You know, I've seen a couple of patients that have really bad scoliosis or really significant disc symptoms or disc findings, I should say, yet we're totally asymptomatic, you know, and so they come for an unrelated problem, but you look at their pictures or you look at their body and you say, wow, you know, at first thought you'd think they would be in a lot of pain. So it's very important to correlate what we see on these pictures with the findings and not just assume that because you have these findings on your pictures that you will have severe or any symptoms for that matter. So our best diagnostic tool is really to listen to our patients. The patient's story as well as their physical exam tells us a lot more than the pictures do. Everyone's got some disc bulge, and some people even have some pretty impressive herniations, but I've seen a lot of patients with those findings on their pictures that are asymptomatic. So I think that's very worthwhile mentioning. So what is the prognosis? You know, a majority of times these things get better on their own. And I'm going to present some literature, but there's a vast amount of literature that says that disc injuries get better with time. Your body does its own healing. And I think this Q puppy demonstrates that. And if nothing, will make you feel a little bit better just on its own. So this was a case that was published in 2016. It was a 29-year-old woman who presented with new onset pain in her right leg, accompanied by numbness or paresthesia. There were no bowel or bladder symptoms, no weakness. These are red flag symptoms that we talk about that will change the treatment strategy. But this patient had a repeat image or MRI done 5 months after her initial MRI was performed. And you see that that disc significantly got better. Now, it's important to go back to that nomenclature and see that that is a significant disc extrusion. And so I'll start talking a little bit about how disc extrusions, particularly sequestrations, get more improvement on MRI findings with time than some of our chronic disc bulges. So the stronger or more impressive the injury, typically the better the outcome for recovery. Right. All right, so there's two studies that I'm going to talk about. Hakelius et al. Took 38 patients who had disc herniation, which was confirmed by myelography, which is a type of MRI. And these patients presented with radicular symptoms or leg symptoms. And of these 38 patients, all of them were treated non-operatively, conservatively. And of those, about 90% were symptom-free at 6 months. And these patients all did physical therapy and took non-steroidal anti-inflammatory medicine. And there was another study by Weber et al. That was a slightly larger study, and they took 126 patients and divided them into about equal groups. 66 of those 126 patients were treated conservatively, and the other 60 were treated surgically. And this study took a look a little bit farther out. So At about 1 year, 40 of the 66 had a good or fair result. 17 of those 66 had been operated on or converted to the surgical group, and 9 were still in pretty severe pain. But at 4 years, 5 of the conservatively treated patients were still suffering from sciatica. The other patients were symptom-free. And importantly, if you look at some of these longer-term studies, by 4 years or 5 years, a lot of these studies that we look at show no significant difference between the surgical group and the conservative group. So a lot of these studies show that in the short term, surgery will improve your symptoms a little faster, but in the long term, the results of getting surgery or sticking to the conservative path are equivocal. And Komori did a study that looked at the natural history of a herniated nucleus pulposus with radicular symptoms. And this is a retrospective study that looked at the changes in the MRI with conservative treatment with unilateral leg pain from a herniated nucleus pulposus who didn't have central lumbar canal stenosis or chronic changes related to these findings. And they took 77 patients with radiculopathy. They did a repeat MRI at 150 days, and they found that the morphologic changes corresponding to the clinical outcome in half of these cases showed some improvement at follow-up. And so the migrated disc herniation had an obvious decrease in size, and in even a few cases disappeared entirely in 7 of those patients. So the further the herniated nucleus pulposus had migrated, the more decrease in size could be observed. So I like to talk about this with my patients because I think that it's very reassuring for them to know that this really impressive thing that we see on their MRI oftentimes, most of the time, heals just with time. And usually, 150 days is about 6 months out. So we see that, the bigger the disc herniation, the more recovery you have on your own. And so our treatment plan is really just to kind of hold you over and let your body do its own healing. And this last line, it's important to mention, if you have a protrusion or a disc bulge, that often showed little or no change on follow-up MRI. So some of these more indolent or chronic disc injuries, those are the ones that end up needing to have more aggressive treatment, whether that be injections or surgical care. This is a really interesting study by Dr. Akithoda and Dr. Polsteris that was done in 2019. And this is 40 patients that they looked at who had a disc injury confirmed on MRI and mild clinical weakness. So the relevance of that is if you have weakness and a disc injury with leg symptoms, oftentimes these patients are quickly rushed to surgery. But this is a pretty groundbreaking study that showed that even if you have a little bit of weakness, which we as physicians grade on a 5-point scale, so if you have 4 out of 5 strength, that you don't need surgery necessarily. And even these patients, which are often considered surgical candidates right off the bat, can get away with trying conservative care. And in this case, when surgery was offered to these patients, 33 of the 40 didn't have surgery initially, and a lot of them maintained non-surgical course and got significantly better, 60% of those. And so you can see that their function and their strength improved significantly over a 12-month period. And so I think this is really encouraging and reassuring for our patients that you really don't need surgery. So we're going to talk a little bit about the treatment options. We're going to talk about physical therapy, medications, some injections, as well as surgical treatments. And I'm going to switch over to our physical therapist, Caryn, who's going to talk to you a little bit about the incidence of these problems with the disc herniation in the low back, as well as all the different physical therapy options. Take it away, Caryn.
Well, good evening. My name is Caryn Szameitat, and I'm a physical therapist here at Boulder Center for Orthopedics. And I want to follow up Dr. Igolnikov's talk tonight by talking to you about treatments, physical therapy treatments for the low back, but specifically their efficacy. So we're going to look at treatments that have been proven in the literature to make a positive outcome towards your low back recovery. So low back pain is really a big problem in the US and globally. Right now, it is the leading cause of disability worldwide. And the incidence of it has been increasing in the past couple decades. Low back pain is going to affect people of all ages. And most adults are going to have low back pain at some point in their adult life. The best research we have right now is showing that about a third of the people that have low back pain are going to have a recurrence of it within a year of recovering from their previous episode. So it's a big problem and it's becoming a bigger problem. And I hope you can see that, and then you can understand why it's important for physical therapists to strive to provide treatments that are going to help towards that recovery. We want to make sure we're doing treatments that have proven to be effective. And when I say recovery and improved outcomes, really I mean two things. Okay, reducing your pain and getting you back to function. Those are going to be the big goals for physical therapy. And return to function is going to look different for everybody. For a lot of people, it might be getting back to work or getting back to gardening and walking, maybe hiking, biking, running. We could go on and on with all those recreational activities that you want to get back to. And so before I get into the treatments that we're going to go over, I just want to make it clear that there's no way for me to tell you in this moment which of these treatments is going to be the right one for you. You would still need a physical therapy evaluation to figure that out. And so when you see images on the screen, just know that they're examples. They're examples to give you an idea of this type of treatment. So the first one we're going to talk about, this category is called Mobilization and Manipulation. So manipulation being a high velocity, low amplitude thrust maneuver targeted at the spine. And mobilization is going to be a low amplitude or slow movements performed by the therapist targeted at the lumbar spine also. And these two categories have been shown to be effective for patients with back pain from that acute phase all the way through chronic phases. So acute being when you have that first incident, those first few weeks of back pain, it's new. And chronic being anything that's gone on for longer than 3 months. These treatments have really been shown to help with pain modulation, so reducing your levels of pain. And for that reason, they really are best combined with more active treatments, which we are going to get into. Okay, so the next category of treatment we're going to talk about is motor control exercise. And this is often called core stabilization. So the goal with this treatment is to target those smaller stabilizing muscles in the spine that are going to contribute to your ability to be aware of your posture and to reduce your pain. So those are the big categories for those. And these are shown to be effective with people who have subacute pain, so it's gone on for a little bit longer, a month or two, and that chronic low back pain. The next category is called directional preference activities, and this one can be a little more confusing. So I'm going to take a few minutes just to differentiate these terms of peripheralization and centralization. So you can see on this lovely picture here, it's supposed to be demonstrating somebody with low back pain who is also dealing with some referred pain down their leg. When this happens, it's called peripheralization of your symptoms. Now, if that pain was to move up out of the leg and back towards the back, lessening the overall symptoms, that's called centralization. I have one more picture here just to demonstrate that. You can see the arrow going towards peripheralization is showing that pain, a demonstration of that pain getting further and further down the leg, and vice versa, that arrow towards centralization where it's coming up out of the leg into the back. So basically, when you're at your evaluation, your therapist is going to take you through some different movements in different directions. And when that therapist does that, if you have this experience of centralization, where the symptoms move up the leg, out of the leg, they are probably going to prescribe some of those activities for you for home. Okay. Here are some examples of those. You can see we've got movements that bring you into flexion, movements that go into extension, and also into a lateral glide. All right, our next category I've titled Endurance, Fitness, and Strengthening. And this is a really big category, and it's a really important category. The activities that fall into this category have good evidence to show that they can reduce the chances of your pain becoming a chronic pain situation, and they can reduce the chances of it becoming recurrent, where you're having it happen over and over again. And this category has a lot of activities in it to choose from. And again, your therapist would have to work with you to see what is best for you, but we're looking at Pilates, yoga, some strengthening, weights, aerobic activities, functional exercise, plank positions. I mean, there's so many things that fall into this category. And at this point, the research is not really showing that any of these are better than others. They're all effective. So I guess that's good news. All right, next category is going to be dry needling. So dry needling is the use of a fine filament needle that's inserted into the muscle. And the goal of this treatment is to improve the neuromuscular connection and improve the resting tone of the muscles. And there is moderate evidence to show that dry needling is going to reduce the intensity of the pain you're experiencing. So again, it's one of those treatments that's going to be good to be combined with some of these more active treatments. All right, this is our last category of treatment, and I've just titled it Education. Your physical therapist is going to be able to provide you some really valuable education to help you reduce your disability related to low back pain, okay? They're going to be going over the anatomy of the back and help you to understand how that anatomy inherently makes your back very strong, okay? They are going to help you to learn to move without fear, because that is a big piece of this back pain problem, is being afraid to move once you've had an incident. So they're going to help you find ways to do that. And they're going to help you to get back to movement and exercise even when that pain is not all the way gone, okay? The therapist is also going to educate you and help you to understand that low back pain has a largely favorable prognosis and people can return to function after having episodes, okay? And they're also going to help you to understand pain and your perception of pain and how that is affecting your disability. And so, again, you are going to need to have a physical therapy evaluation to figure out which of these treatments is going to be best for you. And in reality, it's probably going to be a combination of these treatments to get your pain down and to get you back to function. So your evaluation is going to be very specific to you, individualized, and thorough, okay? And last bit of information I want to share is if you are having your very first episode of low back pain, there is good evidence that if you get in and have some physical therapy done right away, get going with the program, you are going to reduce your chances of that pain becoming a chronic situation. So that is really all I have for you tonight, and I will be around to answer questions at the end if you have any about what I talked about. Thank you.
That was great. And so we're going to continue on and talk about some of the other treatment options. And medications is often a question that I get in terms of what is the best thing to treat these patients with. And in terms of acute disc injury, non-steroidal anti-inflammatories are our go-to medicine. So these medicines are effective in the short term in treating low back pain. We often recommend people stop taking these continuously at the 4-week period, just because at that point, the side effect profile of these becomes more significant and the benefit of taking an anti-inflammatory kind of wears off. You know, your body compensates for you taking anti-inflammatory medications as it does when you take any medicine by kind of upregulating the inflammatory cascade. So at about 4 weeks, we say that the benefit of taking these medicines is outweighed by the risk. You know, if you keep taking these chronically, you can have injury to your heart, your kidneys, as well as your other peripheral muscles and joints, ligaments, tendons, in terms of impairing some healing chronically. So we really try to keep people to taking these 4 weeks continuously. Now, if you take these every once in a while, once every few days, once a week, you can do that, but we just don't want you taking these medicines every day for more than a month. And there is a lack of evidence for the benefit of using these long-term. It has been studied, but there's, like I said, minimal evidence for continuing to take these over time. Opioids are often prescribed short-term for really severe pain. And there's a lot of problems with these. Obviously, we live in a world where there's an opioid epidemic. Longer-term efficacy of taking these medicines is unclear, but even if you take these for the short term, there's aberrant use or addiction behavior that occurs in 25% of cases. You know, these medicines can be started with great intentions, but in a significant amount of patients, these end up being very bad drugs. And so I try to stay clear of recommending these in the short term or in the long term. But even in the short term, you know, I'd much rather get somebody a stronger anti-inflammatory injection, which I'll talk about in just a second, rather than prescribing an opioid medicine. And so continuing along, there's different types of injections that we do for low back pain that is related to a disc injury with leg symptoms. The main thing people have heard of or that gets performed is a corticosteroid epidural injection. Now, these are very strong anti-inflammatory drugs that are delivered directly into the epidural space right next to where that disc is pushing on that nerve. It helps calm down those irritated nerves. It doesn't fix the problem. It just holds you over while your body does its own healing. As I mentioned with the radiographic evidence, you know, your body in a majority of cases heals those disc injuries in the course of around 6 months to 9 months. And so there's great studies that are done by Dr. Saul, as well as a Danish study that was more recently published that shows that these injections work better when they're done in conjunction with physical therapy, which makes sense because as you do physical therapy, your body sends more blood and more healing, more nutrients to the disc, to the spine. And so while we're holding you over with the Band-Aid, you know, it's really in your best interest to continue doing the exercises that are going to help your body heal. Bush did a really good study in 1992 where he took 165 patients treated with an epidural steroid injection who had sciatica or radicular symptoms, and their pain improved by an average of 94% with an epidural steroid injection. And a majority of these cases had a herniated or herniation of their nucleus pulposus or their lumbar disc. 26% of these patients had a bulge, and a majority of them had partial or complete resolution. In the long term, again, 85, 90% of these patients were treated non-surgically. And long term for this study was greater than 1 year. So how are these injections done? When we do them, the standard of care is to do them with live X-ray or what's called fluoroscopic guidance. The whole procedure takes about 10 minutes. You know, we can see exactly where the needle needs to go. This right here is the needle as it comes from the back. It goes in the top half of the neuroforamen, right above where the nerve comes out and where the disc is. And so we put that medicine right here. We do this procedure very safely in that it's done with the live X-ray. It's done in our surgery center just for added safety. The whole thing takes about 10 minutes of the needle being in your back. And again, as you've seen from some of that literature I just presented, it's an efficacious treatment. The side effect profile from these is very favorable. In my practice and in the literature, I mean, the side effects of these are 3 to 5%. The most common side effect being someone has a vasovagal episode or faints. And that only happens in about 3% of patients. Put this slide in here just to say, you know, we don't try to give people too many injections. The safe number of injections to give of a corticosteroid is about 4 in a year. Now, that being said, most of my patients don't even get to that. These injections each injection typically holds a patient over for about 3 to 6 months. And so our goal is to really do 1 or 2 of these. And if that isn't working, we start talking about more involved treatment i.e. surgery. Before we get to there, I'll talk a little bit about some of the more advanced injections that can be done. These are regenerative medicine, and regenerative medicine into the spine is still not too well studied. Desai and all in 2019 did a review of orthobiologics and spine care, and they really found only one study that had level 1 evidence for treating of discogenic pain. There's a lot of level 3 or level 4, which are not as high quality studies. The problem with these is that we really want to see long-term follow-up data, as well as the fact that a lot of regenerative medicine is still not standardized. So you can do PRP injections, mesenchymal signaling cells, oftentimes called stem cells injections, but these things are not one and the same from center to center. There's leukocyte rich, leukocyte poor, different activating factors that you can add to these. And like I said, the treatments aren't followed up at this point for more than a year. A lot of these studies only look at patients for 6 weeks, 12 weeks, 6 months. And so we really need to get more data before I would fully endorse doing these kinds of injections. That being said, we do these treatments at Boulder Center. I just kind of caution patients that the research on it is still out. So I don't quote literature when I do these injections, and I often tell people kind of they're safe, but kind of proceed at your own risk. So Szameitat did a long-term analysis of orthobiologics in 2018, and this was the only review that I found that had a long-term analysis, and they only reached level 3 evidence. Again, there was a small sample size, and the injectate characteristics were inconsistent, meaning they looked at different centers or different studies, and they tried to compare, and it's really hard because there's a lot of different places that do these injections a little differently. And so it's hard to add up data from a lot of different places because you're not comparing apples to apples. And lastly, we'll talk a little bit about surgical treatments. Discectomy is the standard of care for patients who have a disc injury in their spine. This entails, discectomy means cut out. So the surgeon will cut out the part of the disc that's outside of the nucleus pulposus, that's the normal area of the disc. And a lot of times patients' understanding of this is that it fixes the problem. And I often tell patients it does take away to go back to that donut analogy, the jelly that is outside of the disc or outside of the donut, but it doesn't sew back up the hole in the donut. And so you still have to be very careful in your activities that you do, and it'll take care of your symptoms, but it will not entirely fix the problem. It doesn't put the jelly back into the donut, is how I tell patients. And so this is really indicated for patients who have weakness, incontinence, or loss of balance symptoms. And by that, I mean, if that disc is pushing on that nerve so much and injuring that nerve so much that it's affecting the nerve function in the leg, you really need to go in there surgically and clean that disc up, or that disc that has the herniation up. Otherwise, the indication in the absence of any of these severe or red flag symptoms is that this is an elective procedure. So just having a lot of pain, even if it is a severe amount of pain, it's still an elective procedure. And the standard of care is to try to proceed conservatively. And so the article that is referenced very often is the SPORT trial. It's written by Weinstein, and it was done in 2006. It's a large-scale, multi-center, randomized control trial evaluating surgical versus non-surgical outcomes. And they showed improved function and pain in the short term in the surgical arm. But as I've mentioned a couple times, at 2 years, these outcomes kind of equalize. And this is for patients who don't have weakness or incontinence or any of those red flag symptoms. So if you take patients who just have severe pain, in the short term, surgery will make your pain better, more likely. But even as early as 2 years, it's a wash whether you get surgery or not in terms of your functional outcome. So surgery at this point is up to the patient if they really can't tolerate the symptoms. And I've seen it. Patients come in crying, they can't sleep, they can't do anything, they can't sit, which is oftentimes the presenting symptom in a low back pain with radicular symptoms. If even resting positions cause you a severe amount of pain and you can't get any rest, yeah, sometimes patients proceed with surgery, and that's very reasonable, but over time, the outcome ends up being the same. So in summary, about 90+% of patients who have improvement of symptoms within 6 months with conservative or non-operative care. The size of disc herniations decreases over time. More impressive discs improve quicker. So a sequestered disc herniation shows the greatest degree of spontaneous reabsorption, whereas protrusions and disc bulges or more chronic injuries show less improvement. Physical therapy can help, typically in conjunction with epidural steroid injection, which can significantly help hold a patient over until your body does its own healing. Regenerative options are in the pipeline. Proceed with caution. They're still in the works. Maybe in the next 5 to 10 years, we'll have better evidence for them. And surgery is really only necessary for severe weakness, incontinence, loss of balance symptoms related to that nerve compression, or as on an elective basis due to non-healing, persistent injuries, or in severe pain situations. So on that note, thank you guys for tuning in, and Caryn and I are happy to answer any questions you might have.